Hello everyone, welcome back to the channel. Today we are going to discuss a very important topic in oral medicine, lichen planus, especially oral lichen planus. So, lichen planus is a common chronic inflammatory mucocutaneous disease. It affects between 0.5 to 2.2% of the population. It can involve skin only, oral mucosa only, or both. Oral involvement is seen in a large number of patients. Unlike skin lesions, which are usually self-limiting within 2 years, oral lichen planus tends to be more persistent and chronic with periodic intervals. So basically, it's an immune-mediated disorder mainly driven by T lymphocytes attacking the basal layer of the epithelium, and it typically affects people between 30 to 70 years of age and is rare in children. So that was an introduction of oral lichen planus. Now moving forward towards etiology and pathogenesis. Let's start with etiology and pathogenesis. The exact cause is still unknown. It is believed that an external antigen stimulates Langerhans cells, which then activate CD4 and CD8 T cells. These cytotoxic T cells release perforins and cytokines that cause apoptosis of basal keratinocytes. It has been associated with hepatitis C in some countries, stress, and graft versus host disease. Important exam point is there is a low but definite risk of malignant transformation into squamous cell carcinoma, approximately 0.4 to 2% after long-standing disease. Now coming at the clinical types. Oral lichen planus has three main clinical forms. Number 1, reticular, number 2, erosive, and number 3, plaque type. Mixed forms are very common. Lesions are usually bilateral and symmetric. They commonly appear on the buccal mucosa, buccal vestibule, tongue, and gingiva. It usually spares the hard palate. Now coming at the reticular lichen planus. The most common and classic form is reticular lichen planus. It presents as a thin, raised, white lines forming a lace-like or net-like pattern called Wickham striae on an erythematous background. See here, you can see erythematous background with net-like pattern of white lines forming there. It is most frequently seen on the buccal mucosa. Patients are usually asymptomatic, and the condition is often discovered during routine dental examination. It may become sensitive only if erosive changes develop. Now coming at the erosive and plaque forms. Next is erosive lichen planus. This is the symptomatic and more severe form. It shows red erosive areas mixed with white striae at the periphery. Patients complain of soreness, burning sensation, and sensitivity to hot, cold, spicy foods and alcohol. Touching the area causes pain and sometimes bleeding. Plaque lichen planus appears as white, raised, or flat plaques commonly on the dorsal tongue and can clinically resemble leukoplakia. Atrophic and bullous forms are also seen but are less common. Now, moving on to the next slide. Cutaneous lichen planus. As the name suggests, it is present on skin. Skin lesions appears as purplish, polygonal, itchy papules with wide keratotic tops. They commonly occur on the flexor surface of wrists, arms, and legs. A very important feature is the Kobnev phenomena. New lesions appear along lines of scratching or trauma. Skin lesions may accompany oral lesions in 35 to 44% of cases. Now moving to the important part is histopathology. Histopathology is very characteristic and frequently asked in exam. We see a dense band-like lymphocytic infiltrate, mainly T cells, at the epithelium connective tissue junction. There is a basal cell vacuolization, liquefaction degeneration, and sawtooth rete. Apoptotic keratinocytes are seen as Civatte bodies. On direct immunofluorescence, there is a shaggy fibrinogen deposit at the basement membrane, and it is negative for IgG, IgM, and IgA. Now, coming at to the diagnosis and its differentials. So, the diagnosis of reticular lichen planus can be made clinically due to its classic appearance. However, erosive and plaque forms always require biopsy for confirmation and to rule out malignancy. Differential diagnosis includes number 1, mucous membrane pemphigoid, pemphigus vulgaris, candidiasis, discoid lupus erythematosus, leukoplakia for plaque type. Graft versus host disease can produce identical oral and histological features. Now, coming to the treatment in the next slide. So, asymptomatic reticular lesions usually need only regular observation. Symptomatic and erosive forms require treatment. Topical corticosteroids such as fluconazide, clobetasol, or halobetasol are the first line treatment. In severe or widespread cases, systemic steroids like prednisone taper are used. Resistant cases may need immunosuppressant like azathioprine. There is no permanent cure. The goal is to control symptoms and prevent its intervals of coming back. Long-term follow-up is mandatory because of the malignant potential. Now, moving on to the important slide, some high yield plus MCQs. Here are the most important high yield points for FCPS and BDS exams. Diagnostic clinical sign is Wickham Striae. Histological hallmark is band-like T-cell infiltrate plus Civatte bodies. Immunofluorescence finding is Shaggy fibrinogen at basement membrane. Malignant transformation rate is 0.4 to 2%. Drug of choice for erosive OLP is topical potent steroids. So some quick review and MCQs. Classic features of reticular lichen planus, Wickham striae. Main cells involved in pathogenesis are cytotoxic T-cells. True about malignant potential of OLP is low risk but present. Treatment of choice for symptomatic OLP is topical steroids. That's all for today's lecture on oral lichen planus. If you found this helpful, please like, share, and subscribe to our channel Last Night Dentistry. Write your doubts in the comments. Stay consistent with your studies. Thank you so much for watching. Take care. See you in the next video.